Today we are still continuing with health assessment, and we are going to look at the nervous system, how we assess the nervous system. So I want us to start with the general examination and cranial nervous assessment. And the key questions that you're expected to ask your patient is one, does the patient have a neurological illness? So you have to find out whether the patient has any kind of a neurological illness before you start anything. And then the other is where is the nervous system? Is the pathology located? So you need to know where in the nervous system is this pathology located, so that you can be able to assess and concentrate on the area which you have identified where the pathology is. And then also, what is the pathology? What is the problem of the patient? And what is the kind of infection in the nervous system in relation to where the patient has actually explained and told you. Then there is a mnemonic here which you're going to use for assessing your patient, and it's a Socrates kind of, and when you look at it, each letter means something. So for the case of S, that is the site. Where are the symptoms? So you have to find out where are the symptoms presenting from. What the patient will tell you is, maybe I feel on my back, maybe I feel at my lower limbs, and so forth. So you have to know where the symptoms are, which site is the patient actually telling you. Then the onset, when did the symptoms begin? So you need to know when this patient started feeling those kind of symptoms. Then the characteristics, is it dull kind of pain? Is it a sharp pain? Is it stabbing, burning, and so forth? And then the radiation, is it localized? Localizing meaning, is it only in one area, or it is spreading, meaning it is actually radiating to different maybe sides. It starts from one side, then it keeps on radiating or affecting other areas. And then also the direction, which direction does the pain actually radiate? Then associated factors, you have to know the associated factors, the signs and symptoms associated with the pain. The patient may tell you, if I move my limb, that's when I feel the pain. If I try to bend, that's when I feel the pain. So when the patient tells you such, then it means those are the symptoms that are associated with the pain, and you'll be able to actually help the patient in relation to what symptoms and signs the patient is actually telling you. Then the timing, progression since the onset, how long it has taken, and is the pain increasing, and so forth. So all that you need to know and find out from your patient. Then also excavating or alleviating factors. You have to know what kind of factors or what kind of activities make this patient to feel much more pain, and what kind of maybe activities or what does this patient do in order to reduce the pain. So you need to know all those factors so that you can be able to advise your patient. Then also the severity. Severity matters, and in the case of the severity, we look at the grading symptoms. So you need to know the grading symptoms, for example, pain scales. And in the pain scales, we are supposed to actually know how to scale the pain of our patients. And when we scale the pain of the patients, we can be able to tell how much pain the patient is feeling. And we use sometimes our fingers from 1 to 10, and you tell the patient to tell you how much he feels. Is it in the 5th finger? Then that can be moderate pain. Is it in the 9th finger? Then that one can maybe tell you this patient is having some kind of severe pain. So we should be able to grade the severity of our patient's pain. So here we are looking at the neurological examination. How do you examine your patient neurologically? And here we have first to look at the history features, the speed of the onset, the rapid of pain, and we look at the vesicular, the edema, or the infectiveness of the pain. So we have to look at this, and this can help us also to understand the cause and the kind of condition that the patient has. Then also maybe within seconds, the patient may tell you I have some seizures, and seizures is just like a convulsion that the patient may express. And then also there is migraine. Migraine is like headache, and when a patient has headache, that is also related to the nervous system. And then infective, maybe infection, and then also inflammatory kind of factors. A patient might explain to you that I feel there is something happening here, this part was not like this, but now I feel like it is swollen. And also the time when you're examining your patient, you may realize that there is some swelling along some areas that the patient is showing you. Then also the progression, is the thing progressing very fast or slowly? And sometimes the neoplasms, those are like kind of cancers. Sometimes they progress very slowly. By the time you realize, it has actually manifested beyond management. Then degenerative kind of disorders, those ones also they progress very slowly. Degenerative disorders can be maybe some kind of the nervous kind of conditions which can affect either the spinal cord and so forth. And sometimes patients can express lower back pain, and yet it is a degenerative kind of disorder. You also have to find out the duration, brief episodes, because some of them can start slowly, like epilepsy, and also some can start very fast, and when it starts it's so rapid. So you have to find out the duration of this onset. How did it start? How long has it taken? And so forth. Then also the frequency, you have to witness, and the patient may tell you that I felt it starting like this, but now it is increasing or it has reduced. So witness descriptions are important for episodic loss of consciousness, especially on those ones for epilepsy, because we all understand patients with epilepsy have different kind of epilepsy and they present in different ways. So epilepsy is one of the neurological kind of conditions that some patients may present to you with. Motor examination, we have to look at this, and it is one of the systematic nervous system examination. So you have to observe. So observation is very important. Look at the posture of your patient, the muscle tone, and then also involuntary movements of the muscles. Wasting, is the patient actually losing weight, and then the fastulation of your patient. So you have to look at all this, and it will help you understand what your patient is going through, and you'll be able to help them. The other one is systematic assessment. So on the systematic assessment, you have to look at the upper limbs, look at the neck, the trunk, the lower extremities, and then the proximal to distal. So you start from the nearest to the farthest. So you have to examine something closer to the one that is further from you. So that is how we are going to look at this, and then see what could be happening in the lower limbs, in the upper limbs, what could be happening around the neck, the trunk, and the lower extremities. So you have also to observe the major muscle groups, and the major muscle groups can be around the abdomen, around the chest, and so forth. So you have to look at that and see, is there any kind of degeneration, is there any kind of muscle wasting, and then also what is the muscle tone around those different major muscle groups. Then also you have to have a detailed examination if issues identified. So when you identify any issue around those muscles, you have to make sure that you do a detailed examination to help you understand more what is happening with the patient. Then sensory examination, on your assessment, you have to look at the proprioception, then also the balance. Is the patient is he limping, is he bending on one side? Then sensory stimuli, is the patient having a stimuli? Or when you try to make someone you touch, but the person does not feel any sensation like you have touched him. When you try to give someone something to smell, they cannot smell, and then hearing, they cannot hear. So sometimes those are the sensory sensations that we need to actually also assess whether they are able to understand any stimuli in relation to those sensory organs or systems. Then the cortical sensory function, you also have to look at that. as we assess our patients. Then reflex activities. We understand some of the reflex activities like the gripping and so forth. So some of the integrated examinations we need to consider in relation to the nervous system can be the skull, the spine configurations, we need to know that. Then the neck stiffness. There are so many things that affect the nervous system and cause stiffness of the neck, like meningitis and so forth. Then eardrums for otitis media, you also have to assess that because it can affect our patients in their hearing system, which is one of the sensory organs. Then also the blood pressure, the heart, the carotid arteries, we have to look at that. Then check for the neoplasms and jaundice. Neoplasms are basically some kind of cancers that we need to assess. When you look at the mental function examination on general observation, you have to look at the appearance of your patient. And when you look at the appearance of the patient, if the patient is not groomed and is unkempt, then there is a problem with the mental status of your patient. Then also the behavior. When your patient comes to you and you look at a weird kind of behavior of your patient, then you should be able to understand that there is something which is not going right with this patient, and you may need to help this patient come out of it. So when a patient comes to you and the patient is behaving in this bewildered kind of behavior, that means your patient is having maybe a kind of confusion, and you need to understand that this patient should be having a mental problem. And some of them may be restless, some of them can be agitated and all that. So you have to look at that, the behavior, you look at the appearance and also the emotional status of your patient. Some of them can come and they are so depressed, some of them are so excited, so elevated in their moods, and some of them can be hostile. So all that you have to assess in relation to the mental function of your patient. Then gather input from nurses, healthcare practitioners, and relatives. So you can get more information from your colleagues. If you were not there when the patient came, you can also find out from them, how was this patient when you first interacted with him. And other healthcare practitioners, they can also tell you, including the relatives. They may tell you this patient, or this boy, this man, this lady has been behaving in this kind of manner, and that's why we have brought her for your help. So you have to listen and also gather all information from those different individuals. The other is our consciousness level of your patient. You have to assess the consciousness level of the patient. Is the patient conscious and conscious also on? Then also assess the responsiveness to stimuli. Is the patient responding if you call? Is the patient responding when you try to pinch? And you'll be able to actually assess the level of consciousness this patient responds on sound, on call when you call, or the patient responds on pain when you try to pinch or prick. Then the patient can try to maybe change his position or also open the eyes. So consciousness level is assessed in using a Glasgow Coma scale for a standardized assessment. So when you're using the Glasgow Coma scale, it's up to a total of 15. So you have to gauge and you have to give the different scores so that you can come up with the total kind of consciousness of your patient in relation to the total score of 15. So for the case of the Glasgow Coma scale, you have to do the rapid assessment of the level of consciousness of your patient, then also measures behaviors associated with conscious activities, and then indirect measure of consciousness. So there are so many ways you can use to assess the Glasgow Coma scale of your patient in relation to the consciousness levels. Then also you have to utilize in conjunction with other vital signs and imagings. So when you do the Glasgow Coma scale, you can also relate the different vital signs that you take from your patient and also other imagings that you may be able to carry out in relation to the different presentations of your patient, especially the CT scan can tell you what is happening in the brain and the different nervous systems of your patient. So this can help you come up with the actual kind of consciousness levels of your patient. In this slide, we are going to look at basically the painful stimuli applications and when you look at this, you're going to use the trapezius kind of pinch or supraorbital pressure, whereby you are just going to pinch, then you see whether the patient is responding, or you press the supraorbital kind of you just put pressure around the supraorbital area, then you'll see whether the patient will respond. So sometimes when they are unconscious or when they are semi-conscious, when they're unconscious, they will not respond. However much you pinch, they will not respond. But sometimes when they are semi-conscious, that's when they'll try either to move away their limbs, or they try to struggle to open the eyes. Then there you'll assess and say that this patient responds to either the pinch or the pressure on the supraorbital area. So you have also to observe the localizing responses, and when you look at this, sometimes the patient will be able to abduct either the limbs, then you'll be able to tell what kind of level of consciousness the patient is presenting. So the language and speech examination, you also have to assess the language and speech examination in relation to the Glasgow scale. So when you assess from the conversation of your patient, you try to speak to that patient. He may be able to respond to you, but sometimes he may not be able to respond. Sometimes the words are clear, sometimes he has uncoordinated speech, or you may not even, he's just like having a murmur. So there you're able also to score the patient's speech in relation to the Glasgow Coma scale, depending on how the patient will respond. So check for difficulty in articulation. The patient may fail to articulate. When you try to tell him what is your name, then he tells you a different thing, or he may also repeat what you're saying. Then use of specific phrases for evaluation. So you can phrase different statements to help you understand whether your patient is actually able to respond to you. Then dysarthria, this is difficulty moving and controlling muscles of the lips, face, and tongue. And you know, when you're speaking, you have to use the lips, you have to, even the facial expression, and the tongue is contributing to our speech. So this is basically trying to tell us that dysarthria is when the patient is having difficulty in using all these muscles in relation to the lips, the face, and the tongue. So when someone is not able to use all these muscles, then the patient may not be able to speak and mention words that you can be able to understand. So there are different types. You have the cerebellar, and that is more of ataxic dysphagia, and that is canty kind of speech, or slurred voice. The patient tries to say, but the voice is not clear. It is somehow slurred in a way that you don't understand what the patient is speaking, but is trying to speak out a certain word, which for you, you don't actually understand. Then lower motor neuron, flaccid dysphagia, that is rasping or monotonous kind of voice. He keeps repeating the same kind of sound. Every question you ask is repeating the same sound. It may not actually be the answer to what you are trying to inquire. So the motor neuron, that is the spastic dysphagia, the speech or the way the person is speaking or responding to you is very slow, and it is kind of harsh speech, whereby you may not understand still what the patient is mentioning. So this is much more of the difficulty and disability in controlling the muscles to speak on both the lips, face, and the tongue. And when you're not able to control all these muscles in relation to these areas, then you'll not be able to actually speak out what is expected of you to mention. And the other is altered voice tone. This is in relation to the extrapyramidal or monotonous kind of, and then slow dyskinesia, and then also there's lower motor neuron, which is slowed. So this one is basically looking at somebody's disability in explaining or mentioning something. So the person will not be able to speak. The person will be trying to mention something but is slurred. Slurred is just like when someone is trying to say something, it takes long to end the word, and when it takes long to end the word, you may not understand exactly what he is trying to mention. And this can be in relation to even the muscles. This can be in relation to the sound. This can be in relation to coordinating the words that the person is trying to actually mention. Then difficulty in finding the right word. They find it difficult to get the right word to respond to you. And this is dysphasia or aphasia, which is a disorder in speech, what mention. They cannot even write and they are not even understanding you. So the different types are basically expressive dysphasia, which is difficult in pronunciation. I ask you something and I tell you, can you also mention it? You're not able to mention it, the word mentioned. So this is expressive dysphasia, which is a disorder or a difficulty in relation to a disability in the nervous system. Then intact understanding. Intact understanding is basically someone not able to understand what you're saying. You speak something, but the person is just looking at you, but you cannot even force him to understand, and you just get to know there is a problem. Then receptive dysphasia, that is fluent speech but poor comprehension. So the patient will speak very well, but the way he has comprehended what you're asking him is basically poor. The way he has interpreted, comprehending is like trying to compose, to articulate certain things. When they are speaking to you, you articulate and you're able to bring out actually what is maybe adequate enough to respond to what you've been asked. So for the case of this, they are not able to have that comprehension. So their comprehension is actually very poor. They cannot comprehend what you are telling them. Then gross dysphasia, this is limited vocabulary and then wrong words. They have limited vocabulary. Everything you ask, they mention the same vocabulary, and even they can tell you wrong words which are not really coordinated to what you expect. And then aphasia and then mutism. Aphasia or mutism is whereby they cannot speak, they are just mute. We're talking to them but they are quiet, they cannot tell you anything, they just open eyes and look at you. Other defects occurring in absence of motor or sensory dysfunction can be dyslexia, dysgraphia, agraphia, acalculi, and also other things that you can see in relation to defects of motor or sensory dysfunction. So here basically these are different terms that mean different kind of disabilities or defects, and I would like us all to look at this and understand what each of these terms is. And I want to say that this is assignment for all of us. I have them, but I decided to just outline them because I want us to take into ourselves to know what these terms mean. And if someone tells you there's dysgraphia, what does it mean? And someone tells that patient has a visual agnosia, what does it mean? Auditory agnosia, what does it mean? So let's try to look at these terms and understand each of them one by one, so that when patients present to us, you don't say this patient is not able to write, this patient is not able to maybe speak, this patient cannot maybe understand or hear. So we really need to understand which term means difficulty in some of those areas. And then parietal lobe lesions, they always neglect. It is just a neglect of the opposite side, because the parietal lobes are on both sides of the parietal bones. So when you look at these parietal lobe lesions, it means there is a lesion on the other side which has affected even the other side of the lobe. Then cognitive function examination, we have to do the assessment and look at exactly what is happening on the cognitive aspect of our patient. So you have to evaluate the intelligence. Cognitive is basically looking at the mind of our patient, looking at the brain of our patient. So it's all about thinking and also using intellectual abilities of our patient. That's what cognitive function means. So when you're assessing this, we have to evaluate the intelligence of our patients, education, and the interests of our patient. Then also covers orientation, thought processes, and also logic. So if our patients are able to understand this, then the patient have a good cognitive ability. You mentioned something in a logical way, but this patient is able to explain to you. So the intelligence of this patient is high, and also the cognitive ability is adequate. Then orientation, you have to check awareness of time, place, person during conversation. And in orientation, you ask, what is the time right now? And you'll be able to tell you, right now it's 8, 8:30 or 9. And when you ask, where are you, he'll tell you, right now I'm in the hospital. Whom are you speaking to? I'm speaking to either nurse or a doctor. And there your patient is well oriented. Then in disorientation, it indicates disruption of the language pathways, whereby the patient will not be able to tell you, and also the cognitive functioning of this patient is also disoriented. So when you ask him where he is, he will tell you, I'm in the market or I'm at home. What is the time now? It is 10 p.m. and yet it is maybe 8 a.m. When you ask whom are you speaking to, I'm speaking to a soldier, instead of saying I'm speaking to a doctor or I'm speaking to a nurse. So the cognitive functioning of this patient is actually disrupted, and the patient will not be able to tell you exactly what is expected in the case of orientation assessment. You have to look at attention, concentration, and also the calculation. In this, you have to test the concentration through mathematical tasks, whereby you can do some calculations and tell him to repeat, or you ask him, if you want to get 1 plus 2, what is it? When you add 1 to 2, that is 1 plus 2. What is the answer? He may tell you it is 8. When you tell him, right now, I want us to get maybe the sum of this number, he will just tell you, I don't know. Or else he will look aside. He will not be looking at you. So the attention and the concentration is disrupted. So you have to assess this in relation to maybe calculations or any mathematical task, and see how is this patient able to concentrate, and what is his attention towards what you're trying to find out from him, and is he able to calculate if you give him a question or a number in mathematics. Then impairment in various conditions. You can also assess different other impairments of this patient in relation to attention, concentration, and either calculation. Then in memory assessment, you can assess the immediate, short-term, new memory, longer-term memories, and the patient to be able to tell you. The immediate is, you might have asked him, what is 1 plus 1? He tells you 2. Then as you repeat within a short time, what is 1 plus 1? Then he'll tell you, I don't know, or 4. Then there you just know this patient's immediate memory is poor. Then short term is not immediate. It may be a bit, maybe after like 4 hours and so forth. Then long term can be something which took time some years ago, and the patient may not be able to remember. Then use mini mental state examination for comprehensive evaluation. So you can do all this to try to evaluate the thinking and the understanding of your patient in relation to the mental status. Then on reasoning, you also have to assess whether your patient is able to reason. Sometimes you can just bring something like an abstract and try to ask him whether he can be able to reason. So you test the abstract thought with proverbs. You can ask something in a proverb way, then the patient may be able to tell you, or he may not be able to interpret what you're telling him. So the reasoning capacity of your patient is also poor. So you have different proverbs that you can use to assess the reasoning capacity of your patient. And here you'll be able to assess whether he has a good reasoning or he has a very poor reasoning capacity. So you have to look at the visual field examination. Visual field examination is basically looking at the visual abilities, your patient's sight, whether the patient is able to see, because this is all in relation to the nervous system. So for the case of the visual field examination, the method you're going to use is to test the temporal, peripheral patient fields. And then also standard method is to hold a small red pin head in the midway plane between the patient and the examiner. So this is just the light that they use to flash into the patient's eye, and you're able to understand and see what is happening in the eye of your patient. Then the peripheral field testing, where this is where the nostril defect in one eye indicates peripheral defect in the other eye. So this one is basically an investigation or some kind of examination, I can say, that the opticians use to help examine the eyes of the patient. So they can look at one of the nose inside and they see maybe there is a defect, then this can affect even the eye on the other side. So sometimes some of these organs, some of these different parts of our bodies coordinate with each other, whereby the nose can be coordinating with the eyes. When there is a problem in the nose, you see the eye is also affected. Someone can have running eyes. When the person is having painful eyes, even the person can be having running nose. So there are connections in the different areas in relation to the nervous system, and when one part is affected, even the other can be what affected. So you also have to use the waggling finger to test the awareness. So this one, you're testing whether your patient is able to see. Your fingers, you can show one, and then you try to move it along the face of your patient and ask. When you see that the eyes are able to move following the finger, when you bring it down, it's able to see. When you bring it up on the side and so forth, as you're asking the patient, and be able to tell you you've moved it on the right, you've moved it on the left, you brought it down, and so forth. So on the visual field examination, as we continue, you also have to look at the standard method for central field defects. So you use a small red pin head to assess the scotoma or enlarged pin blind spots. So this is just the light that you flash into the eyes. And for the case of the opticians or ophthalmologists, for them, they are being taught that when you see this, this means this condition, when you see this, and so forth. So they are able to explain and interpret the different defects and the different kind of maybe abnormal kind of either growth or abnormal appearances of the different parts of our eyes, and they're able to tell that this is what is happening in this patient's eye. So test for the sensory inattention when fields are full with both eyes open. So they are able to do this using the pinhead kind of light. And then the patterns of visual field defects, you have to indicate the location of the lesion in the optic pathway. So the optic pathway is basically these different parts of the eyes, and you can be able to identify when you use this pinhead. You can be able to tell that the defect is either in this part of the eye, and you know all those parts, the different labelings on those parts of the eyes. So you can be able to tell that on this part, that's where I'm seeing maybe some grayish or whitish kind of growth and so forth. So the patient can be telling you, I'm feeling pain in the eyes, but it's now you to identify where exactly. So the optic pathways may include either the retina, the optic nerve, or the optic kind of chiasma, and then other parts of the eyes. So that is the pathway, the optic pathway of the eye, different organs or different parts within the eye. So you can be able to tell this lesion is either in the retina or this lesion is in the optic nerve, and so forth, looking at the optic pathway. So also examine the fundi, and you can be able to tell. So relevant lesions can grow along these optic pathways, and you can be able to tell which part exactly is affected. So you can have either optic atrophy, whereby the optic nerves or any part of the optic pathway is affected and has atrophied. So you can see a pale disc along that area, and also you can see a demyelination kind of appearance, and you'll be able to tell that this is a lesion around this part. Then the papilloedema can also occur, which is caused by raised intracranial pressure, and so many patients, they feel a lot of headache, they feel the head is paining because the eye is affected, and most of them is due to increased intracranial pressure, which has been caused by the papilloedema. So this can also affect the eyes of our patient and the visual field of our patients. Then when you look at the nystagmus, many times people actually look at this kind of patients and they think it is just a kind of maybe they look at it and they think someone feels like he should put his eyes in that manner, but sometimes can be due to a defect in relation to the nervous system. So the sensitive test during the fundoscopy can be done. So you ask the patient to cover the other eye to elicit nystagmus. So you'll realize that when the patient is covering one eye, the other eye is not able to concentrate looking at one side. So it keeps shaking abnormally in a way that it is not normal when you see it behaving in that way. So this is a sign of a nystagmus kind of condition in our patients. So the cranial nerves, like 1, which is the optic, and then 3, which is the oculomotor, in most cases is the one that is what affected. So when you look at the pupil, when you examine the pupil, you check for round and equal pupils, which is around 2 to 5 millimeter. So when you see that is not like that, then there is a problem. Then evaluate the symmetric small or large pupils. You also evaluate whether they are symmetric. Symmetric meaning, are they of the same size or they are not of the same size. So what is the problem? Then aniscoria, this is asymmetric pupils, whereby you realize one is bigger than the other, or one is dilated and one is normal. So you have to look at all this. So they may include various conditions that are happening in your patient's eye. Then light reflexes, you can also flash in the light at the eyes of your patient and you see how the patient is responding. So you check for equal contraction of the pupils, whether both of them are contracting or it is only one and the other is not contracting. Then evaluate the conditions like the Holmes kind of RD pupil. You also have to see that whether it has that kind of disability. So it is one of the conditions that affects the pupils. So it is not just a term, but it means a disease that affects our patients, our pupils. So it is a neurological kind of disorder that affects the pupils of the eye and may cause some kind of autonomic nervous system defect. So it is in relation to the autonomic nervous system, and the patients may present with that kind of condition. So when you look at accommodation reflex, we also need to assess the pupil's response to accommodation, but not light. And accommodation is the ability to focus and ability to see. And this differentiates the conditions like Argyll, Robertson, and then the Holmes-Ardai pupils. So when you look at the trigeminal nerve, that's where we look at the accommodation reflexes. So the trigeminal nerve looks at the sensory, which is more of light touch. When you touch the patient's near the eye, how does the patient respond? So testing all 3 divisions with cotton wool. So what you do, you get just something like cotton wool, then you try to move it closer to the patient's eye along the eyelashes, along the lids, just around the patient's eye, and see how the patient is responding, whether he's able to blink his eyes or he's leaving the eyes open. Then also test the pinch prick if needed in relation to assessing the trigeminal nerve response or reflexes in accommodation. Then the corneal reflex, this is the sensory and the motor kind of assessment in the 5th and the 7th nerve, and you'll be able to also tell what is happening in relation to the corneal reflexes. So you ask the patient to look up and away, tell the patient to look up and then also look somewhere else far, and then touch the cornea with the cotton wool. Then you can be able to see that the patient is able to blink or close the eyes. But if he's not able, then there is a problem with accommodation. So both eyes should always blink. When you try to put cotton on one side, then the eye on that side where you have tried to check the reflexes is blinking, then that means even the other side will automatically have to blink. You cannot blink one eye and leave the other open, then it is abnormal. I don't know whether we have ever tried to experience that. When something is maybe trying to fall on the other eye, on the right hand eye, even the left hand eye will always try to blink. It will not remain open. So if you try to do it, you will see how your eyes will respond. And then the motor nerve 5, muscles of the jaw. Ask the patient to open their mouth against resistance. You try to put resistance on the jaw of the patient and tell them to open. Then also check for the jaw deviation, and that is pulse causes deviation to the side of the lesion. So where there is a lesion, it will not allow the jaw to open all in the same way. So you try to open, but due to the effect of that palsy, and palsy is basically looking at the failure of the jaw to actually open, and when you try to do it, then you may end up injuring the patient's jaw. So jaw jack test can be done, and only if other neurological findings suggest an upper motor neuron lesion. Then also have to increase jaw jack increased jaw jack indicates a bilateral upper motor neuron, which is the fifth nerve lesion. So when these nerves are affected, that means they always cause a certain kind of condition. So when you assess your patient and you see that the patient has this problem, then you know that it is that nerve that is basically causing, or it is that nerve that has a problem that has caused that condition. So when you read this kind of this topic, I mean the nervous system, try to relate when this nerve is affected, what kind of condition does it cause? And if a patient has this problem, that means it is this nerve which has what? A problem, so that we can be able to coordinate and actuate different conditions in relation to the different nerves in the nervous system. So the nerve 6, that is the abducens nerve, we also have to examine for nystagmus. And when you're doing this, you have to test in the neutral position and with eyes deviated right, left, and upwards. So when you're testing, you have to tell the patient to tell you, can you put your eyes, or try to turn your eyes, look left, look right, look upward, look down, and the patient may be able to do that. But when they are not able to do that, then you know there is a problem with this nerve. Then keep object within the binocular field, and nystagmus normal in extreme gases. So when you tell the patient to look at maybe a certain object and is able to see it in a certain angle, but when you tell him to turn this side or to look at his left, his right, and is not able to see, then you just know there is a problem with the patient's fields of seeing what is expected for them to see in those different angles. Then movements should be always smooth. The movements of the patient, when you tell him turn your left, should not be straining, should not be struggling, should not be actually causing a discomfort. The patient should be always shifty in doing it. When you tell him turn on your right, look left, it looks, look right, it looks, but not that he's straining, he's struggling, he's trying, but he's not able, then you know there is a problem. Because in a normal person, you should not have difficulty when they are telling you, face this way. You just turn and see. Turn your eyes right, turn your eyes left, and you're able to do it in an easy manner. Then the cerebellar nystagmus, fast movement to side of the gas, both sides. So the patient can be able to move those eyes in those different sides very fast, and then increased when looking toward the lesion. Cerebellar or brainstem lesion, or drugs. So this can be due to this problem. It can be due to a brain stimulation, or it can be due to certain drugs, which can cause this kind of cerebral nystagmus, where there is increased a kind of shaking of the eyes when they are looking towards that side where there is a lesion. So the lesion can be on the right hand side, but now when you tell the patient to look at that side, the patient's eyes blink, they keep blinking several times, whereby they are not able to concentrate and focus on what you are telling them to look at. Then the vestibular nystagmus, that is the first movement only in one direction away from the lesion. So when you tell them to turn on the other side where there is no lesion, they are able to do it, and it is very fast. Then reduced by fixation if peripheral, then more marked when looking away, that is the inner ear vestibular disease or brain stimulation. So if it is a kind of a peripheral kind of problem, then the patient may not be able to actually look at something which is away from them. So you have to look at this and you'll be able to know that the patient has a problem, whether in the inner ear, or the patient has a vestibular disease, or the patient has a brain stem lesion. That's why I was saying that we need to understand the causes of these different disabilities in the nervous system, which can help us also identify the different causes of these conditions, so that when the patient is presenting that, then you're able to tell that the problem could be in this way, or the problem should be maybe the cause of this kind of disability or the defect in this part of the nervous system. And also I mentioned that when the patient has a problem in any part of our bodies within the head, then you should know that there are connections in those different parts in our bodies, whereby now when you look at this, the inner ear has a problem with this vestibular nystagmus, then also the vestibular disease, and also the brainstem. So the ear itself contributes to that, whereby it affects the sight. So even sometimes the conditions that are in the nose can affect either the ear or the eye. So some of these things coordinate and they connect to each other. And then this labyrinthine nystagmus positional. For example, it is a benign positional vertigo. So benign is more of it's much more looking at something which is affecting the cells, and may be something of cancerous. So when you look at this, you should not take it lightly, because it can be like a tumor, and some tumors may end up being so dangerous to the lives of our patients. So some benigns can be removed, but some, when you tamper with them, they end up actually causing more complications. So it is induced by neck hyperextension and rotation. So when the patient is having this problem, and maybe you make the patient to extend the neck, or to rotate, or to move his neck, then it can cause this problem more and more of danger to the patient. So you have to know what are the aggravating factors, what are the relieving factors, and so forth. So when the patient tells you, when I do this, when I try to extend my neck, or when I try to move it on the side, I feel a lot of pain. So this can help us in the way we handle and the advice we give to our patients in relation to the different conditions that they present. And that means we need to understand the different conditions that patients present, especially now in relation to the nervous system. So after latency produces the vertical or torsional kind of nystagmus for 10 to 15 seconds. So the torsion is just like that twisting kind of, and remember this is a benign, and in most cases when it is relating to this, it may even cause more harm to our patients, and some of them may end up even having a loss of sight, where they are not able to see well. And when they explain to you, don't think that maybe they are pretending. Sometimes it happens in a way that even them, they don't explain what is happening to them, but they only say, I'm not seeing well, I cannot understand why. But you should not judge your patients, but we need to know what is happening in the lives of our patients. And then the rapid eye movement. In most of our patients with the nystagmus, they always have this rapid eye movements. So rapid eye movement to change eye position. So when they try to change the eye position, they always have that rapid kind of movement. So these patients experience a lot of difficulty in accommodating or trying to see what we expect them to see. So we should not treat them as people who pretend, or we should not treat them in a light way, but they need our help. So you have to test in horizontal and vertical planes by switching fixation between two targets. So you should try to check the sight of our patients, whether they are able to see something which is horizontal in front of them, or something which is on their sides. And those are the different planes. You can use the horizontal, vertical, and see whether they are able to switch their sight into those different areas, so that we can be able to tell what kind of nystagmus condition they have. Then also you have, sometimes they have the slow saccades, or they have the slow rapid eye movements, which may indicate disorders like progressive supranuclear kind of palsy. So palsy is basically like a paralysis whereby the patient is not able to do something, so they can slow, and sometimes they can be what they can be static in a way that they cannot move them. And then the seventh facial nerve, which is um, more of controlling the facial activities, and these motor functions may be raising the eyebrows. The patient may be able to raise the eyebrows in relation to the seventh nerve, then close eyes tightly, and then so smile, frown, show teeth, puff out maybe the cheeks, and so forth. So this seventh nerve is very, very important in relation to the facial activities. The way we try to do anything in relation to our face is always controlled by this facial nerve. So we can assess it for different things, whereby we can see in assessment, you can see the low motor neuron lesion in case it causes the Bell's palsy. And that's when you see one side is bent of somebody's face and one side is normal. So all muscles on the side are affected. Then widened palpebral fissure, and then there's weak blink where the patient is not able to blink. You want to maybe prick the eye of the patient, and he's blinking slowly, not in the same way whereby someone whose eyes are normal, or whose facial nerve is normal, blinks. So dropped his mouth, you find the person's mouth is actually the lower lip is the one that you see when it is dropping. So you realize these muscles are actually affected, and they are not able to control those different parts within the face. Then the upper motor neuron lesion, that is in the lower motor. Now when you look at the upper motor neuron lesion, for it, the only lower muscles are affected. Then the mouth drops to one side, but eyebrows raise normally. The eyebrows can raise normally, but the mouth drops only to one side. So you realize there is a problem with the facial nerve, and it is more of a lesion in the upper motor neuron. The grimace assess the levator palpebrae superioris, that is the oculomotor nerve, and then the sympathetic nerves for the superior tarsal muscles. So you have to observe the patient's grimace for upper and lower muscle affection, and see whether these muscles are related, the upper and the lower muscles. How are they during the time of grimace? Is the patient able to shake the face? Is the patient able to move the facial muscles, and so forth? So it differentiates between the upper and the lower motor neuron and lesions. So when you assess this, it will tell you whether where the neuron is affecting, whether in the upper or in the lower portion. So you test and assess. So on the side of testing, you test on the anterior 2/3 of the tongue. So that's why you find out about this. Then close the eyes, stick out the tongue, apply sweet, sour, or salty kind of solutions, and this can help you know whether the patient is able to know, and also the patient is able to have agreements in his face. Because when you give someone something which is sour, there is a way the person will express, and it is due to the facial salty, the patient agreements. So all this can be assessed in relation to the facial expression of our patients, and we shall be able to explain whether the patient has a problem with his oculomotor nerve or not. When you look at the vestibular and the ocular kind of nerves, we can also be able to tell what is happening. So this can be done in different ways. So we can be able to assess the hearing, we can be able to assess the whispers, and we can be able to assess the rhymes test and also the Weber's test. So for the case of hearing assessment, when you look at the whispers test, what are you supposed to do? So for the case of the whispers test, we are going to block one ear, then we whisper. You can whisper either numbers, or you can whisper just a word and ask the patient to tell you what you have whispered. So there is when we are assessing for the whisper test. So you tell the patient close one ear, then he covers one ear, then you whisper to him maybe one. Then the patient will be able to tell you, you have mentioned one. But some of them, when you ask, they cannot even remember what you have told them. Then for the case of the Rennes test, you compare bone and air condition. So we use always we use always what there is an instrument, or there is an object that we use for testing. The tuning fork is the one that we use for testing the Renner's test and also the Weber's test, and we are able to ask the patient. So when you test for the Renner's test, you're going to compare the bone and the air condition using the tuning fork. So you ask the patient, you hit and then you put on the patient's face, the facial bone, and you ask, what have you had? Then after, you also put at the back of his ear, then also you ask whether he has heard something. So the patient will be able either to tell you he has heard any sound or vibration, or he has not had any vibration or any sound. So you can be able to compare the bone and the air condition. Then the Weber's test can also be assessed. You can assess the sound localization on the head. So you'll find the patient seated, then you try to use the tuning fork, then you'll ask the patient the same questions. If he has heard any sound, which side of the head, is it on the left hand side or on the right hand side? So the patient will be able to tell you the localization of the sound within the different sides of his head, and we use this all in the with the help of the tuning fork. So basically, this is what we had to cover this morning, and I think we come to the end of our session. I encourage all of us to go through this, and when we are going through this, let's try to read more, and let's try to understand what each kind of condition in relation to this nervous system is, and how do these patients present when they come to us, so that we can be able to understand the different nerves that are affected, and which kind of conditions that they always give to our patients, and how do these patients present when they come and they're having this kind of conditions. So thank you very much. We may have another session in the course of the day. Have a good Sunday.